Welcome, everybody. We are going to kick off the event in about 2 minutes to give everybody some time to jump on today. Let's give everybody 1 more minute. Alrighty, so it looks like we are at that 12:02 mark, so that's my cue to go ahead and kick things off. Thank you so much to everybody for joining us today. My name is Emily Kunish, and I'm the Senior Marketing Manager here at First Stop Health. We are a virtual care company serving more than 740 employers and about 750,000 members nationwide. I'm thrilled to be moderating today's panel discussion, where we will be discussing virtual primary care and how employers can statistically improve employee health by implementing a high engagement virtual primary care strategy. A few things to note before we kick off today's event. This will be recorded and we will send it out later this week in a follow-up email. And also please feel free to drop in any questions into the Q&A and we will do our best to get to them at the end of today's session. However, if we don't have time, we will share the answers in the same follow-up email with the recording. So I'm joined by 2 incredible panelists who will each be representing an important voice in this conversation. Dr. Derek Baughman, a physician and researcher, will be walking us through evidence that virtual care can meaningfully improve health outcomes over in-person care, and Elena Gambon, our Chief Strategy Officer, who will be sharing more detail about how First Stop Health deploys primary care and the perspectives from our employer clients. Dr. Baughman, Elena, would you like to introduce yourselves?
Thanks, Emily. Hey, everybody, thanks for coming out. My name is Derek Baughman. I'm a family medicine trained physician. My current role is a medical director. I'm active duty Air Force. I direct a primary care on a base in Louisiana. And we receive multiple parts of primary care, and we do telehealth as well on base. And then part-time, I work for a private health system where I'm a telemedicine physician, and I see my own small panel of patients, and have had some pretty fulfilling and satisfying experiences there. I'll tell you more about that in a little bit, and very excited to be here. Elena.
Thanks, Dr. Baughman. It really is always such a pleasure to be on a panel with you. I learn so much every time I'm here. My name is Elena. I'm the Chief Growth and Strategy Officer at First Stop Health. I have been sort of at the intersection of employee benefits and digital health my entire career, most notably spending a large amount of time in navigation and transparency, which has actually become a really important component of our primary care product. So you'll hear me talk a little bit about this today, but one of the things that we think is so critical to care delivered virtually, and one of the things that we think makes virtual primary care so exceptionally great at improving health outcomes, is because it is oftentimes more comprehensive and more coordinated than traditional care, and offers some additional touch points that traditional primary care might not. So really excited to dig into that today, and to hear a little bit about Dr. Baughman's research.
Wonderful. Well, thank you so much for joining us today. The format for today's event is a combination of presentation, panel discussion, and of course a Q&A. We will be talking topics including statistical evidence that virtual care can outperform in-person care modalities, We'll review the current state of primary care as well as some areas for improvement. We will also talk the merits of virtual care and engagement strategies. And lastly, clinically, how virtual primary care can address chronic disease and mental and behavioral health. So the question posed on this slide is one of the two questions that we will be answering today. Is the quality of virtual care and in-office care comparable? And so what? Why should an employer or benefits consultant pay attention to the caliber of care delivered virtually? We're going to go ahead and start with this first question, and I'll turn it over to Dr. Baughman to review his research that will help us answer it. Dr. Baughman, over to you.
Thanks, Emily. So in addition to seeing patients, one of my other passions is medical research and health systems research. And I've been leading a team for a couple of years now investigating this question of quality of telemedicine care. Before I can really talk to you about the methods and how we're coming to some of these conclusions, I need to talk a little bit about this slide and reviewing standardized measures of quality. So many of you on the call may be familiar with HEDIS measures, which are standardized quality measures, and these are endorsed by the National Quality Forum, which many of you may know. And it's essentially a large organization that has a lot of big stakeholders. And this is everyone from all the doctor and medical organizations to pharmaceutical companies, insurance companies, et cetera. And this group comes together. And once they endorse these quality measures, they are used broadly throughout the healthcare industry, including the government. So the quality measures are so important because they're tied to reimbursement, and we all know that the payers have a big play in how healthcare gets delivered. And there are specific HEDIS measures that are designed for different types of healthcare, and including primary care. And these are, of course, all bundled into the whole concept of value-based payment. So with a little bit of knowledge of quality measures, we can go on to the next slide. And I would like to share what our team has been doing over the past couple of years. So we explored this question of, is telemedicine a good idea, and can you do it with quality? So we started out with just one of those quality measures. And you see on the left side of the screen there, that was with the HbA1c, or what we use to screen for diabetes. Many of you may be aware of that. And we published that initially as a research letter in JAMA. And that kind of gave us the rough start to be able to say methodologically, well, how can we study this in a population across a health system, which is what we set out to do. So over the next couple publications, we used more and more of those measures and took it piece by piece until we kind of developed a good system. And so we explored another measure in back pain, imaging, and another one in BMI screening. And then that eventually led us to this large paper, which was published just this past fall in JAMA as well, and where we actually took 16 of the 22 measures in the primary care set. And you'll see on the slide that says in process, we have another project that we just submitted for publication that will be that's comparing hospital follow-ups between telemedicine and office care. So happy to answer questions about that later. We can go to the next slide. And what I'd like to highlight is how we did these studies. So this schema is from our big paper on the 16 HEDIS measures all in one, but it serves as a template for all the studies. So in the 16 HEDIS measures study, we took about 500,000 patients across an 8-hospital health system. And these were patients that were filtered out to only be seen by primary care. So it would exclude any patients that are seen in surgery or emergency rooms, et cetera. And we set a study time frame to observe the pandemic because we were trying to, again, understand that quality and the surge of the whole, the pandemic-related telemedicine surge. In those blue boxes, you can see how we divided these patients. So of those 500,000 patients, we were able to separate out patients who had some sort of telemedicine exposure, whether that was only telemedicine or a combination of telemedicine and office, and compare that group to those who just had office care. And then from that point, we were able to take those two cohorts and do what's in the green box. And in the green box, you're seeing a very rough math equation of what a HEDIS measure calculation looks like, or a quality measure calculation looks like. And that's every measure has its own inclusion and exclusion criteria. And you can see the example in the red box for colon cancer, for example. And then that really builds the numerators and denominators, which builds a percentage, which is essentially what builds a quality measure or a HEDIS measure. And you can see those dotted lines out there. We were actually able to compare the performance of the office and then compare that to the patients who were exposed with telemedicine. We can go to the next slide. And I want to reorient you to the fact that we use standardized measures in this set. And the beauty of this is that it allows us to compare that quality across different venues, because we're not reinventing methods here. We're using standardized methods. And again, overall, we've looked at about 19 of those 22 measures, which is about 86% of the primary care specific quality measures. We can go to the next slide. So we tried to break this down in our results of discussion into pieces that would help general audience understand what are the applications of telemedicine quality. And really, we want to know as researchers, where should we be doing more telemedicine or not? And as someone who is a telemedicine physician, I actually had the senior operations manager or director rather for our health system reach out to me about this study, and we're working with the team to expand the pilot that I'm part of to actually start gearing patient visits toward the results that I'm going to present to you right now, which is pretty cool. So you can see on the screen that there are 3 different groupings of measures that we came up with in this large study, which you'll see there's medication-based measures, testing, and then counseling-based. So if we look at the top of the screen there on those medication-based measures, and those are in green, what you're seeing on the columns in those 2 gray boxes is the office-only cohort, and that's that same 400,000 compared to that same 100,000 patients. And what I want you to take away from this is that office care for medication-based measures, this would be stuff like if a patient had a heart attack and were they on an antiplatelet or a cholesterol medicine, that percentage of quality is not that much different than the telemedicine. And these medication-based measures were the only ones where office was a little better or about the same. But if you see those red numbers, only 3 of the 5 comparisons in the medication category were statistically significant. For the rest of them, it's about 5% or less, so not much different. So moving forward, everything else was better in the telemedicine group. So if we look at the testing-based measures, we called it moderately better performance in this category. And you can see the example of DM is diabetes. So if you think of a diabetes patient who we're screening, or we are checking their kidneys and nephropathy testing, those testing-based measures for someone who was seen over telemedicine had better quality performance in the study timeframe. Similarly, in our last category there of counseling-based measures, this is where we really argued that telemedicine shined the most. So in counseling, so this would be for types of cancer screenings. You can see all the different types of cancer listed in the chart there. And this would be in addition to tobacco counseling and vaccine compliance, and especially depression screening, which is consistent with the other literature that telemedicine is actually doing really well in the behavioral health category. So all those counseling-based measures, we call this considerately better because it was at least 5 to up to 17% better, depending on which measure you look at. So this is a really important slide because it shows us that even for the spots where the office may have been a little bit better, it's not much different. And overall, it's mostly better. So we can go to the next slide, Emily. So I've been talking at you for about 5 or 10 minutes straight here. I'd like to pull away some takeaways before I turn it over to Elena. And these are the 3 biggest things that are probably most important to you all as an audience. So firstly, if you're going to expose patients to telemedicine, it's probably going to augment your value-based care. And we argued in our research that telemedicine is able to promote more of those quality performance building opportunities because it's just easier to access the care. And then on if you think of the negative impact, well, you might be asking, well, what's my risk if I have my patients start being seen for telemedicine? Well, I mean, you just saw on the last slide, the risk of you having a decreased quality performance is pretty low, but your reward is pretty high if you do add telemedicine. So that's important. And the third point that we argued in our research is how telemedicine has such value because it can increase that capacity to be able to see patients just astronomically. And again, it's all in the context of probably not impacting your quality performance, and there's a good chance it can make it even better. Go to the next slide. I'm happy to come back to this slide later, but this will be emailed out. And this is just a highlight of the five different papers that we've published on this topic. And it largely shows that telemedicine can be pretty effective regarding quality performance. And it really sheds a lot of light on where and how can we be using more telemedicine effectively to improve health outcomes in our patients. So Elena, I will turn it over to you.
Dr. Baughman, thank you so much for this amazing information. I'll ask the audience to keep this data in mind as we shift into a macro discussion around why these findings are so important with our panelists. So Elena, I will turn to you for the first question. At a high level, why should an employer or a broker care about this research? In essence, so what?
Yep. So the reason they should care is really because this is actually one of the first questions that I get when I'm talking to an employer about primary care delivered virtually. And the reason is because we generally know and believe as a group, as a market, that when primary care is used and delivered effectively, it's actually an incredibly powerful tool to mitigate healthcare costs and improve outcomes. So patients who see a primary care physician on average incur 30 to 33% lower per member per year costs. They have more preventive screenings. They use less unnecessary services like ER visits. They have lower rates of mortality and morbidity. And so we know primary care is a good thing. But the problem is so very few patients are actually seeing a primary care physician one time, let alone more continuity. And so the problem really can be demonstrated by this number that you see on the left-hand side of the screen, which is that about 60% of US adults have had no primary care in the last 2 to 3 years, either because they don't have a doctor or they just haven't seen their own doctor. And this is often due to costs, patient inertia, a lack of proactivity, provider shortages, having to wait a very long time to actually get in to see a physician, which kind of points to some of those provider capacity issues that Dr. Baughman was speaking about. And so this becomes important because we know if a virtual solution can meaningfully close that gap, if it can turn 60% into say 30 or 20 or 10 by addressing some of these access barriers, that's meaningful. And the question then becomes, what's the quality of the care that I am then subjecting my employees to? I now know that it's going to improve the access, but is the quality of the care the same? And if knowing that the caliber of the care is either equal to or in some cases better, then employers can confidently make a decision to deploy a virtual care strategy to solve the problems of access, but also meaningfully reduce gaps in prevention and increase rates of chronic disease management. So it becomes an important question when thinking about holistically putting in a program that is not just solving one problem of access, but also solving a problem of access to quality.
Thank you so much for sharing, Elena. Dr. Baughman, if we could stay on this trend for just a moment, why exactly is it so important to an employer that a patient see a primary care physician? What's going on in that clinical setting that a patient isn't getting at a like a retail clinic, an urgent care center, or even at a specialist?
Yeah, thanks, Emily. I'd say the short answer to this is that that's just not the design of retail clinics or urgent care clinics or specialists. PCPs do a different kind of a job. So heart disease, cancer, diabetes, these are some of the commonest diseases in the US. And most of these are either manageable, preventable, or even curable. And patients just aren't going to get that by going to an urgent care or just showing up at a retail clinic when they feel like they need to. What our research shows is that telemedicine can actually meet some of the goals of these diseases, managing, curing, preventing, with comparable quality, even as they would be seen in the office. So, and a lot of this, as we were highlighting in the research, is it involves a lot of screening, counseling, helping patients to stop smoking, manage their mental health, or really just get these chronic diseases under control. And that's where the PCP comes in, because it's the preventive mindset, and that prevention is really key. And I always like to use the example of getting your car oil changed. People understand this concept. You don't feel like you need it, but that little sticker on your windshield reminds you, okay, it's time to go again, because you know that preventive care for your car is going to prevent that axle breaking down, or they're going to find that part before your car leaves you hanging on the side of the road. And that care for your car could be life-saving. And that's really the kind of attitude, that culture change that we have to have when we're thinking about if you're an employer thinking about your employees. You want those employees to be able to be healthy, and they're not gonna get a comparable care elsewhere as they would with a PCP.
Thank you so much for sharing, Dr. Baughman. That's a really great comparison. So if virtual care is equal in clinical caliber, how exactly does it help improve utilization? Elena, I'm going to pass this question off to you.
Yeah. So there's really kind of two ways to answer this question. So the first is in the nature of virtual care itself, and how inherently the fact that it is virtual enables higher levels of use. And then the second is really more specific to how we've designed our program. So I'll go into both. As it pertains to the innate qualities of virtual care that promote utilization, we all kind of have a general sense of what this is, right? It's just easier to turn on your computer or pick up your phone and talk to a doctor than it is to get in the car, drive to the visit, maybe drop your kiddos off at daycare or a neighbor's house while you go, take time off of work, and then see a physician who is usually available, Monday through Friday, 8 to 3, 8 to 4 in the middle of the day. There's other components of it, including that broadened access from an hours perspective, right? Brick and mortar facilities typically have weekday limited availability. Virtual care has the ability, because there is no physical asset to maintain, to expand hours into the morning, evening after work, and even weekend appointments. And then the other component is really the fact that a provider can spend more time with a patient in a virtual environment, because they are able to go from patient to charting to review to another patient at a more efficient pace than they would be if they were physically with a patient. There are some components of our solution that go above and beyond these innate qualities of virtual care to promote utilization. On average, our book of business utilization is about 45%. And that is because of a couple of things. Number one, our model is truly value-based. So we operate off of a capitated model where we are at risk for our clients' success, in that we deliver performance guarantees on utilization. And if we do not hit them, we pay the client back. So inherent in the revenue structure in our business model is risk for the success of this program. And we are aligned with the client's desire to get as many people into primary care as possible. The second component is, because our solution includes clinical care, but also does so much more than that. You'll see on the screen that clinical care is sort of one of the three prongs of this three-pronged primary care stool. The fact that we also have coordination and a sort of hub of engagement means that we're myopically focused on making sure that patients aren't just coming into their first primary care visit, but they're coming back and getting their follow-up and closing gaps in adherence. And so part of it is the product that we've delivered. It's not just the virtual visit, it's what happens after the virtual visit and before the virtual visit to make sure that the program is being used. And the third kind of piece of what makes our solution different is that we fully fund and manage and customize our engagement strategies for clients. So we are directly speaking to and reaching out to patients to make sure that they're aware of the solution, they know how to use it, that engagement is sort of customized to them based on their demographic and their age and their gender, and that the messaging really resonates with them. So it becomes a kind of, a no pun intended, a first stop that people go to when they want to use healthcare. And virtual care really becomes a buffer, if you will, between a patient population and the plan that supports them more broadly, because we really become the first place that they go if they want to access care.
Thank you so much for sharing, Elena. Dr. Baughman, I'd like to dig a little bit more into the patient experience side of things here. I think we have a pretty good sense how virtual care can enhance adherence to prevention, but how exactly does virtual care enhance the ongoing management of chronic issues?
Yeah, thanks, Emily. I'm going to go ahead and insert the catchphrase here that the how is that touch points with patients equals trust. And simply, that's just something telemedicine can facilitate easier, as Elena just pointed out. So it's important to recognize that medicine, although we made a lot of progress in the screening for and the management of chronic disease, this is something we handle every day as PCPs. The goal of that routine check-in with the PCP is that you build this relationship that helps patients make better choices consistently. And that cumulative effect, those cumulative touch points, builds that trust so that when it's time to start that medication, when it's time to make that treatment plan, that chronic disease gets managed, and it gets managed effectively. So I'll pivot to talking about what we found in our research is that telemedicine is actually pretty effective in chronic disease management. Remember, that was one of the areas on the chart. And this is really true for a couple specific diseases. And these are big diseases like cardiovascular disease, so hypertension, hyperlipidemia, diabetes. As we know, hypertension is the #1 cause of stroke and MI, heart attacks, and those are the top two of the top 3 killers in the United States. So the virtual care's ability to enhance that adherence to prevention is just so key with these touch points. And that's really the main way that telemedicine is going to enhance that disease management. It's through that follow-up engagement with the telehealth that causes lots of continued management that happens with, it doesn't just stop at the visit, it goes on with patient with portal messaging, ability to touch that provider even indirectly. And in between visiting counters, however you want to describe it, but this increases that access for patients, and that's what is really promoting those health enhancing opportunities. And as we argue again in the research, that's what enhances your quality of performance. But the most important thing is that it's actually helping to manage the chronic disease better.
Thank you for sharing. And from your perspective as a physician, Dr. Baughman, how do patients, especially those used to the in-person care, respond to virtual visits?
I have had a lot of great experiences, not just personally, but with patients. So I'll share that in a minute, but I'd also like to assert that part of all this research is we had to do a lot of literature review. And what we found in the literature, and literature's demonstrated that patients have a high satisfaction in telemedicine care, and they like the convenience, they like the engagement, they like the fact that they feel like they have control of their plans, and there's evidence that shows that they become more adherent to those plans. And from a personal experience, from a practice standpoint, I've had countless reports from patients who have enjoyed the telemedicine process. And especially for me in working evening hours, I will share an anecdote that's not really a specific patient, but kind of a group of patients. And These category of patients are after hours patients coming in for upper respiratory infections and urinary tract infections. And I see these patients, almost every night I do telemedicine. And patients are frequently thanking me for having these evening hours. And they tell me, I wouldn't be able to accommodate this schedule otherwise. If you didn't have this, I'd be in the ED. And these are often either patients or who work late night shift, or they have kids in sports after school programs, or you get those adults say, hey, I know I'm sick and I don't want to be in the ER, the older patients. So I always respond with something like, hey, I'm happy to help. But when I reflect on these things as a physician, these are those interactions that make me recognize that I'm so valuable to patients and that I really make a difference in their lives. And I'm consistently saving them from 3-hour ER trips and frustrated Googling. And this is what they tell me. Yeah, these patients really make so I hope that gives some glimpses on both the provider and the patient side. But again, I don't think I can highlight enough much value that the telemed has here, because it's this ability to augment the care capacity, and that includes out of hours access for the patients who the most. And this is really just this nice side effect of improving your quality performance.
Yeah, absolutely. The expansion of access to care is huge with virtual care. So we've talked a lot about the role primary care physicians play with physical health, but we know they also are incredibly impactful in mental health care as well. We know this in our own program, where about a third of patients are talking about behavioral health. Statistically, 50% of adults will be diagnosed with a mental illness at some point in their lifetime, and that generally shows up in a primary care setting. And if a patient has a chronic disease, they're actually 3 times more likely to develop a mental health issue. So Dr. Baughman, what are your experiences with and thoughts on helping patients with mental and physical well-being?
This is a huge topic, and it's becoming more and more important as telemedicine We might have lost Dr. Baughman for a moment. So as he's reconnecting, Elena, I'll pass the question along to you. How are employers thinking about using primary care as a mental health enhancement strategy?
Yeah, absolutely. So the first thing I will say is that almost all of our clients who have partnered with us for primary care have also partnered with us for our virtual counseling. They really are a masterful pair, and the clients that we work with, typically when they are making an investment in virtual care, they tend to agree with us that mental and physical health are inexorably linked, as you've sort of shown us here, Emily, with these statistics. Now, there are components of primary care, and when Dr. Baughman rejoins, I'm sure he'll give you the clinical perspective on this. There are components of primary care on its own that can support mental health. So the first component of primary care that supports mental health is the use of virtual screenings. So there are a number of virtual screenings that can be done at the beginning of a primary care relationship and at every ongoing visit where appropriate, that can help a doctor and a patient better understand where a patient's mental health status is, even if they don't themselves know or feel like that's a risk for them. So one of the things we screen for is, you may have heard of the PHQ-9 or the GAD-7. In those screenings, we're looking at the levels of anxiety and depression that exist within a patient. And those screenings are intended to signal to the doctor what degree of intervention might be helpful for the patient, as well as how that patient is improving over time across those metrics. The other component of primary care that really supports mental health is the fact that primary care is actually an incredible site for non-controlled psychotropic administration. It's a really long, wordy phrase. And what I mean by that is most primary care physicians actually prescribe things like anti-anxiety or anti-depression medication and they prescribe them at a higher rate than psychiatrists. And the reason being is that there's a huge psychiatrist shortage in the United States, and about 40% of psychiatrists are not actually in network. So when a patient needs something like an anti-anxiety or an antidepressant, they are often better served seeing a primary care physician who can not only prescribe that medication, help titrate it, help make sure that it's the appropriate dosage by seeing them repeatedly over time in a more cost-effective environment, but they can also treat them for comorbidities that might be showing up along with that anxiety and that depression, like weight gain, or a lack of sleep, or a loss of appetite, or headaches, or stomach aches. So we really think about this, in combination with counseling, but also discreetly, it is incredibly valuable to manage conditions. And then the last kind of thing we do in primary care that's related to mental health is a lot of, and I alluded to this, a lot of conditions that are physical are presenting with a mental health comorbidity. People with diabetes, for example, people living with diabetes have a higher likelihood of depression than those not living with diabetes, and vice versa. So it is important for the primary care practitioner to weigh in on the mental health care journey and help a patient understand how their physical condition might be impacting their mental health and vice versa. And I see that Dr. Baughman has rejoined. So I'd be curious, Dr. Baughman, if you have anything to add from your clinical experience treating patients specifically on the mental health spectrum.
Yes, ma'am. Sorry about that, folks. I would like to comment, and there's so mental and physical well-being intimately related. I treat a lot of behavioral health on telemedicine. I would say probably between 30 and 40% of what I see regularly on when I have telemed hours is behavioral health. I'm thinking of several patients that I have on my panel who I regularly manage for their mental health problems, mostly anxiety, depression. I see a lot of that. And many of these patients they're either in school or they may not have time to seek out that traditional behavioral healthcare like other patients would. And many of them have had a distaste for behavioral therapy. So, I do some of that myself. But what I find with these patients in particular is that I call it a digital rapport. And this is similar to those touch points and building that trust. And that digital rapport I've established with these patients, there's something intimate about this environment of being in their home, and I'm in my home, and you're over a video call, and you're not only able to help control their behavioral health illnesses, but that digital rapport builds this trust needed to be able to try alternative therapies that maybe they hadn't been interested in before. And this has opened the door to me diagnosing all sorts of things, bipolar, ADHD. These are things I diagnose regularly because I'm able to manage these problems in a real way that patients trust me to do. And I would say furthermore, as these patients become more comfortable, they're also more open for me managing other diseases as well, other conditions, doing more screening, making medication adjustments, messaging me in between visits. So I just think it's a really important aspect to remember, that this is not just something I'm experiencing as a physician or my patients are. This is something that we're seeing in the research, in the research that we've done, that depression screening is actually better with telemedicine. And recall that this is consistent with the broader medical literature, that telemedicine is very consistent in behavioral health care.
Thank you so much for sharing, Dr. Baughman. So we're going to move on to our next slide. So I would like to note that it's important to acknowledge that there are limits to what virtual care can do. So a question an employer might ask is, sure, virtual care is increasing access and utilization, but is it just duplicating spend or creating unnecessary utilization? Meaning, is it actually replacing in-person visits and impacting trend? Elena, I will pass this question to you.
Yeah, this is a super important question. And the way that I'd like to answer it is by kind of grounding us in what I've said, I think, previously today, which is we believe primary care utilization is a good thing. Even if it were slightly duplicative, more touch points equal more trust. So you want people in their primary care relationship. However, studies have shown that, in fact, patients who use a primary care physician virtually are not duplicating the costs, meaning they are not then turning around and seeing an in-person primary care physician to compensate basically for what was lacking in the virtual visit. And there have been studies done most recently, and when you see these slides come to you in email, you can click on the link. Epic Research did a really interesting study with a couple of million patients, and they found that 75% of commercial patients who used a primary care physician virtually did not need any in-person follow-up to clinically complete the visit because the virtual visit was comprehensive. Thereby answering your question, Emily, it is not just adding unnecessary cost. It is in fact replacing a person's primary care visit or creating a primary care visit where there was none. The kind of tail question I get here is when we think about what's happening in a primary care visit and what can be completed virtually and what can't be completed virtually, there's really three important things that happen in a primary care visit. And Dr. Baughman, keep me honest and tell me if you agree with this. So the first is conversation, communication, collecting a patient's history, developing trust, motivational interviewing, helping a patient understand kind of what their lived health reality is and their capacity for behavior change, if that's important to their clinical journey. The second component of an in-person visit might be laying hands on a patient, palpating lymph nodes, looking in ears, listening to chest sounds. And then the third component is what I like to call diagnostics. So that might be getting labs drawn, maybe sending someone out for an x-ray, maybe taking blood pressure. Statistically, the most important parts of the visit of those three components are the first and the second piece, the communication and the diagnostics. Laying hands on a patient has historically not demonstrated statistically any impactful improvements on mortality and morbidity over time. The most important thing a practitioner can do is ensure adherence to diagnostics and preventive mechanisms and establishing a relationship. Those are two things that we can accommodate in a primary care setting. Very obviously, primary care lends itself in a virtual environment to more communication, longer visits, more visits. And we have the mechanisms to guide a patient to in-network low-cost resources for when they need a lab, send out blood pressure cuffs for when they need to collect their blood pressure, and kind of support the diagnostic component of this that then feeds back into the virtual visit. So when you're sitting and you're thinking, gosh, my doctor's not, hitting my knee with that, well, I actually don't even know what that's called, which tests reflexes, or is it laying hands on me and listening to my chest sounds? Is it actually a comprehensive visit? Well, data would suggest that it is, because the two most important components of a primary care visit can happen virtually and quite well.
Thank you for sharing, Elena. So I have another question for you. An argument that an employer might make is, why not just use the virtual care delivered by my in-network providers? What is the difference here?
Yeah, this is a very interesting question. So first I'll say, we applaud and appreciate all practitioners delivering care and doing so virtually. There are some specific differences between our virtual care and the virtual care delivered by an in-network provider. And the difference is it's not in modality, but it's in the model of care. So our model is a direct care model. Traditional primary care physicians who are delivering care virtually are still operating in a networked care model. Our model is a capitated, value-based direct care model. There is an unlimited access to visits, zero cost to the patient. And in a traditional setting that is delivered virtually, we think that there are still some realities that may inhibit exponential success of a patient. So for example, traditional primary care physicians, unlike our doctors, typically are not plan aware. They don't necessarily know what the full scope of employee benefits that an employer might offer are. They're not hyper aware of what the formulary status might be for a patient. And they are sort of oftentimes operating in what we'll call a network coverage or a plan vacuum. The second is they're typically fee for service, so they're paid on volume and not value, and that's not true for all primary care practitioners, but for most commercial patients, that's true, which means there's just less time to spend with the patient. And then the third component is there tends to be limited proactivity. So our model is we are reaching out to patients to remind them how to use the solution. After they come visit us, we're reminding them to go get their lab work done. A normal primary care practitioner may not have the bandwidth or the revenue model structured to actually create that level of proactivity. And if you look at patients who use a traditional primary care practitioner, based on a survey that we ran of patients who are not on our primary care, but just our urgent care, about 71% of them admitted to leaving a primary care visit and not planning to follow up on the doctor's recommendations for various reasons. So even though virtual care, across the board is valuable, we think there's room for improvement in a direct model that we employ to enhance the relationship between the patient and the doctor.
Absolutely. And I read a statistic recently that some 79% of physicians actually end up referring patients out of network. So there's definitely some broken care coordination within the system there.
Yep.
So from what you just said, and from what both you and Dr. Baughman touched on a bit earlier today, it sounds like engagement and proactivity, they're really at the heart of a successful virtual care program. So let's just talk about this for a minute. Just being care delivered virtually isn't enough. How does First Stop Health think about engagement?
Yep. So I alluded to this a little bit earlier, but if this solution is not used, it doesn't matter how clinically competent the care is, right? The first step is getting patients into a virtual visit. And we think about engagement really as a function of behavioral science. We know that patients act when three things happen. And this follows, if you're familiar with B.J. Fogg, the renowned social scientist, this sort of follows his philosophy, which is that patients need to have the right motivation. Pain has to be high enough, or they have to understand that the reward for their behavior is high enough, that action is meaningful to them. They have to have the ability to act, meaning the effort to have a visit must be low, the cost to have a visit must be low, the time needed to conduct that visit and actually achieve it must be low. And then lastly, a patient needs to be reminded not only to get their visit, but to come back for their follow-up and to get their labs drawn and to take their medications. And that is not to speak negatively of a patient, it's human nature. We all need reminders. And that messaging, that prompting has to be relevant and it has to be consistent. And so it's our job to design a program that targets motivation, that improves the ability, and that consistently prompts patients to engage with us. And that's been how we've seen such high utilization in urgent care, and that's what we're continuing to do in primary care. And really making sure that that's at the heart of the care engine that we provide.
Wonderful. Well, thank you so much for sharing, Elena, and thank you, Dr. Baughman, for your amazing insights as well. We do have some time to go over some questions, so please don't be shy. Feel free to drop some questions into the Q&A. So we do have one. In your experience, Elena, what forms of employee engagement tend to be the most impactful when it comes to getting employees to use virtual care?
Yeah, so there's a couple of different components here, and what we've found to be really successful is what we call persona-driven messaging. So if anybody here is on social media, if you've ever been targeted with an ad, you know that ad is coming to you not randomly, but because of maybe the activity that you've done online or your age, your gender, where you live. And you're more likely to click on that ad if it's relevant to you. So, a single woman in her 30s is less likely to click on a healthcare message that talks about children than, say, a father of 3 who's dealing with back to school flu and cold season. So we apply that principle of relevance to our messaging, and we find that patients are more likely to click and engage with us if the message resonates with them based on what's going on in how they've used the solution before, their age and their gender. If there's any sort of circumstantial environment that would make urgent care or primary care more relevant, like a natural disaster, they're more likely to click if we're paying attention to that sort of thing. So it really does matter what is in the message and when a patient receives it, as much as just the routine cadence of messaging to a patient.
Wonderful. Thank you for sharing. And then Dr. Baughman, this one is for you. What tends to be, I believe you touched on this a little bit earlier, but what tends to be the top conditions that you have experienced treating in the virtual care setting, and which are some that you see the most improvement with?
I would say top 3 would be probably diabetes, hypertension, and behavioral health. And I don't know if that's necessarily the right order, but those I see every day. I'm thinking of a patient who initially I was seeing for, I was the only provider available that night on telemedicine, and they were out of their diabetes medicine. And I wound up noticing in their chart, I'm like, wait, you haven't had an A1C testing in a while. I don't know what you're due for a couple screenings. And I was like, hey, if I established some good digital rapport quickly, and wound up being able to get her tested, and wound up seeing her diabetes was out of control, and got her on insulin, and wound up saving an emergency room trip. And these aren't uncommon experiences that I have. And I find, especially with diabetes and hypertension, these are frequently conditions where patients think, I have to go to the office. I got to get my blood pressure checked. I got to go do my labs. But what we found, I find this in both my jobs, is that I can get patients to complete lab work or do their blood pressure checks at home, which evidence shows us home ambulatory blood pressure monitoring is more accurate. And patients will trust me to be able to keep a blood pressure log for 2 weeks, and I can adjust their medicine, and then suddenly they're controlled. And same thing with diabetes, same thing with initiating antidepressants or anti-anxiety medication. I would say these 3 conditions, I treat them all the time. Patients love the fact that they can access me, because otherwise these same patients will be driving into the clinic, coming to get their blood pressure checked every 2 weeks, getting labs done, having to come in just for me to tell them, go up on 2 units of insulin, or, hey, cut back on your Zoloft. And it's just so helpful to patients. And again, come back to the research, this is consistent with what we found at the population level with 500,000 patients in a 5-paper study.
Well, thank you so much, Dr. Baughman. We always appreciate your transparency and willingness to share some personal anecdotes. We are approaching the top of the hour, so I would like to give all of our wonderful attendees some time back on their calendars and be respectful of everybody's time. Thank you so much for joining us today, and thank you again to Dr. Baughman and Elena, our incredible panelists. Just a reminder that we will be sending out the recording and a follow-up email in the coming days, as well as any Q&A or any questions that we weren't able to get to. Should you have any additional questions, would like to take advantage of a free impact analysis or request a proposal, please reach out to your First Stop Health representative. If you're not sure who to reach out to, please feel free to email marketing@fshealth.com, and we will point you in the right direction. Thank you so much again, and I hope you all have a wonderful rest of your day and week. Take care, everybody.